Hello and welcome. Today we're diving deep into a rare and complex kidney disease called C3 glomerulopathy, or C3G. This is a disease affecting the glomeruli, the tiny filters within our kidneys, leading to a range of potential health problems. Understanding C3G is crucial for both patients and healthcare professionals, so let's explore the ins and outs of this condition. So, what causes C3 glomerulopathy? Well, it's largely a disease driven by dysregulation of the alternative pathway of the complement system. Think of the complement system as a crucial part of your immune defense. The alternative pathway, one branch of this system, normally helps to clear debris and fight off infections. However, in C3G, this pathway becomes overactive and uncontrolled. This is often due to genetic mutations affecting complement regulatory proteins, or the presence of acquired autoantibodies that interfere with the normal function of these proteins. These factors prevent proper regulation, leading to continuous activation of the alternative pathway. Now let's break down the pathophysiology. In C3G, the overactive alternative complement pathway leads to excessive deposition of C3 fragments, particularly C3b and its breakdown products, within the glomeruli of the kidneys. This deposition triggers inflammation and damages the glomerular structures. Over time, this chronic inflammation and damage can lead to scarring, known as glomerulosclerosis. As the glomeruli become scarred and damaged, they lose their ability to effectively filter waste products from the blood, ultimately leading to kidney dysfunction and potential kidney failure. C3 glomerulopathy is considered a rare disease. Estimating the exact prevalence is challenging due to its complex diagnostic criteria and possible underdiagnosis. However, studies suggest that it accounts for a small percentage of all cases of glomerulonephritis, a broader category of kidney diseases affecting the glomeruli. It can affect individuals of all ages, from children to adults, with some reports suggesting a slightly higher incidence in younger individuals. The signs and symptoms of C3 glomerulopathy can vary from person to person and often develop gradually. Some common symptoms include proteinuria, which is protein in the urine, hematuria, or blood in the urine, and edema, which is swelling, particularly in the legs, ankles, and around the eyes. Hypertension, or high blood pressure, is also frequently seen. As kidney function declines, individuals may experience fatigue, nausea, loss of appetite, and other symptoms associated with kidney failure. Diagnosing C3 glomerulopathy requires a comprehensive approach. It starts with a thorough medical history and physical examination, followed by blood and urine tests to assess kidney function and identify abnormalities such as proteinuria and hematuria. The definitive diagnosis relies on a kidney biopsy. A small sample of kidney tissue is examined under a microscope, looking for the characteristic C3 deposits within the glomeruli. Specialized staining techniques and electron microscopy are used to confirm the diagnosis and differentiate C3G from other similar kidney diseases. Genetic testing may also be performed to identify mutations in complement regulatory genes. C3 glomerulopathy is broadly classified into two main subtypes based on electron microscopy findings: dense deposit disease, or DDD, and C3 glomerulonephritis, or C3GN. In DDD, the electron microscopy shows extremely electron-dense transformation of the glomerular basement membrane. C3GN shows deposits that are not electron-dense within the mesangium, subendothelial, and subepithelial areas. While both subtypes involve C3 dysregulation, the location and nature of these deposits differ, potentially affecting disease progression and response to treatment. This distinction is important, even though treatments often overlap. Treatment for C3 glomerulopathy is focused on managing symptoms, slowing disease progression, and preventing complications. There is no one-size-fits-all cure. Medications used may include ACE inhibitors or ARBs to control blood pressure and reduce proteinuria. Immunosuppressive drugs, such as corticosteroids, mycophenolate mofetil, or rituximab, are often used to suppress the overactive immune system. Eculizumab, a complement inhibitor, may be considered in some cases to directly block the alternative complement pathway. Dialysis or kidney transplantation may be necessary if kidney failure occurs. Unfortunately, there are no specific proven preventative measures for C3 glomerulopathy, primarily because it is often linked to genetic factors. However, early diagnosis and prompt treatment are crucial to slowing the progression of the disease and preserving kidney function. Managing blood pressure, maintaining a healthy lifestyle, and avoiding nephrotoxic medications can also help support overall kidney health. The prognosis for C3 glomerulopathy can be variable. Some individuals may experience a relatively slow progression of kidney disease, while others may develop kidney failure more rapidly. Factors influencing prognosis include the subtype of C3G, the severity of kidney damage at diagnosis, and the response to treatment. Recent research focuses on developing more targeted therapies that specifically address the underlying complement dysregulation in C3G. Clinical trials are underway to evaluate new complement inhibitors and other novel treatments that may offer improved outcomes for patients with this challenging disease. Researchers are also working to better understand the genetic basis of C3G and identify biomarkers that can predict disease progression and response to therapy. It's a constantly evolving field, and we're hopeful for advancements in the future.